When we are live.
Okay. So good morning, everybody. Today, Dr. Meenakshi is busy, so she's asked me to introduce Dr. Nidhi Dhawan so that she can begin our talk. Dr. Nidhi Dhawan is Secretary, IMA North Delhi branch. Is it LDB's New Delhi branch? Associate Medical Director of ENT and Head of Safety Committee, Shroff Charity Eye Hospital, Daryaganj. And today she is going to talk on insulin, too much of a good thing, and of course, Happy Mother's Day. And she's going to talk on emerging pandemics. The little prince says it is difficult to be a human right now. I'm sorry for your suffering. I don't know why. Anyway, so on to you, Dr. Nidhi.
So I think why I put that here is because now what we are seeing in our outpatient departments is a lot of people coming with a lot of persisting problems from the pandemic that we are recognizing. And we see that, you know, somebody has brain fog, somebody has difficulty in sleeping, somebody has anxiety. And most of the people who are persisting with long COVID symptoms or emerging with long COVID symptoms are having a difficult time dealing with it. And there has been so much suffering and grief and pain in the last 2 years that, you know, all you can do is listen to them and tell them, yes, it is difficult being a human right now, but stay with it. We see your suffering and we'll try our best to mitigate it. That's why I put that as the small print, the background. So we'll start here now. We have started the series on lifestyle improvement and enhancement, and we wanted to pick up one unifying string that could tie most of the things together. And what better molecule than insulin? Though insulin itself is regulated by a lot of factors and causes a lot of downhill cascading effects, but we will deal with basics of insulin today. Clinical use of insulin is not my area of strength or of expertise, and it is my request that one of our physician friends will take that on for the next Sunday. So insulin is a good thing, but too much of it is not good and is the hallmark of metabolic syndrome. We'll start off with a very brief overview of what has happened in the last week. The world is having a very difficult time digesting that India is still staying at relatively low numbers. There are several explanations that they are offering, that we are not testing enough, that we are not, our data is not robust enough, and that we are basically hiding things from the world, which I don't think is very true. And I say this with extreme responsibility. We on the field are seeing what we are seeing, and हम कितना magnitude hide कर सकते हैं? 1%, 2%, 10%, 50%. अगर हम अब 50% भी हाइड कर रहे हैं, 100% भी हाइड कर रहे हैं, और हम नंबर्स को डबल भी कर देते हैं, तो 3000 के हम 6000 पर पहुंचते हैं, which is explainable by what Omicron has done in January. If we look at the effective reproduction rate, all countries are coming down. India was at 2.7, 2.8 at the peak of Omicron wave. UK and US have hit that wave around the similar time, and they were at 1.5 and 1.1. Right now, UK is comprehensively down, which is a good news, which means that we seem to have entered the phase in which we can say the pandemic is over. The world picture, US seems to be going through periods of going up and down. Right now, it seems to be on an up phase. The countries which have reported the most deaths each day, US, UK, Germany, Russia, Italy. Apart from US, all European countries. Again, the topic that we are taking on today is very relevant to why this could be happening. The metabolic health of these countries is not stellar. And when WHO releases data saying that India could have fudged to the level of 90% more deaths, I very strongly recommend that you watch Shekhar Gupta's print episode on this topic, and you will see how beautifully he has brought out these statistics and said, and see, he's not pro-establishment by any yardstick. And he has brought out the data which tells us that it is just not possible. It is not tenable what WHO is saying right now about our country. If you look at UK, 11,000 new infections as of last week. Deaths, very low. We saw in the last slide. US, 80,000, 76,000 infections last week and on the rise. Deaths, slightly on the rise. India, 3,805 infections, slightly on the rise. Deaths going down. We had, during our discussions in the last few months, always reiterated that India seems to be doing better than the West, and it is a case study. We are not gloating. We are simply saying that there are reasons why this could be happening. The reasons are India has a relatively younger population. Even though lifestyle diseases are on the rise in India, it's nearly not as high as West. The basic immune status of the population, by virtue of being exposed to tropical diseases, the immune system is primed to respond to newer challenges. And we still didn't do very well in the Delta wave. But at the peak of our Delta wave, we were at around 400,000 cases. And US went more than double that number at their peak. Why it looks like this is happening is because in the US, the narrative has been very, very highly polarized and politicized. So the public health directives begin to suffer and confuse the general population. This is a New York Times report. We are not saying this. New York Times report says that more than 50% of Americans have already been infected by COVID virus at least once. And this is a CDC statement. Now, should that not dictate public health policy? Also, new data is emerging that definitely regarding the the adverse cardiac events during vaccination trials, data has been hidden. If through natural immunity, the population is moving towards herd immunity, the logical public health solution would be to cover high risk groups and then spread to lower risk groups. We know that vaccines do not give sterilizing immunity. That is to say, that a vaccine does not prevent infection. It prevents severe disease, and for that, we need to cover high risk populations. The first world countries have hoarded the vaccines and, in a way, probably done the rest of the world good, because emergence of Omicron provided the natural comprehensive vaccine for the rest of the population. The immune naive versus immune educated population is where our balance of herd immunity and population statistics would veer. If we look at India, we are seeing a slight rise in cases. That rise is small and shallow. It's not steep. Our medical systems are not overwhelmed. We are seeing a few cases in the OPD, but not to the level that we saw in the earlier waves, both Delta and Omicron. It is causing a milder disease, treatable by general principles of medicine in the OPD setting. The active case trajectory is staying close to the baseline, but is still around 20,000 cases. This does mean that there is an opportunity for newer variants to emerge. And this is a number that we must bring down as close to zero as possible. The recoveries are showing an encouraging trend. So if you look at India's curve, it did start rising. It was a slow rise and it seems to have flattened out. Now, if it is flattening, either it can stay a little above the baseline or it can start coming down, which it seems to be doing now. This is something that I could not avoid today, because being Mother's Day, we must talk about maternal health. I'm just putting one slide here for the sake of putting it on the radar that we as doctors need to treat women with a little more. Educate a woman and you educate a family. So we need to treat them with a little more empathy, and I'm not saying sympathy, I'm saying empathy, and educate them about health. The encouraging thing is that our target was to fall below 100 by 2030. In 2022, we have already come to less than 100. This is a very big achievement for India. And you look at where it was nearly 180 in 2010. Coming to insulin now. Insulin is the master hormone of metabolism. There are some indicators whereby, you can diagnose insulin resistance at least from across a room. The size of the waistline. There will be some dark pigmented patches on flexural creases. There can be skin tags. The chemical measures of insulin resistance or disordered insulin metabolism are easily detectable by ordinary and relatively easy to do tests. Elevated fasting glucose, high blood pressure, excessive triglycerides, and low HDL. Interestingly, in the last week, I had a patient who was quite lean, very lean looking, who had symptoms of long COVID, and his lipid profile, everything else was good. The only thing that I saw was low HDL in his lipid profile. Everything else was okay. Now, this is somebody who is on the road to insulin resistance. And this is something that can be picked up early and remedial measures set in place. The emerging health challenges from the last 2 years are not being recognized in our medical and paramedical circles nearly enough. The last few years have seen, last decade, 2 decades, have seen emergence of obesity as a real public health problem. India is called the diabetes capital of the world. With the pandemic, anxiety, depression, grief, sadness have become major issues in mental health landscape. Burnout of most professionals, people want to want to change their professions, resign. In fact, in the US, we are seeing the big resignation wave, and sleep deprivation is another epidemic which is emerging. All these contribute to metabolic dysfunction. All these can be the backdrop of metabolic or X syndrome. These are compounded by when somebody loses the job or resigns from the job and is not doing anything new, when the nutrition is not mindful, then most of the biological parameters seem to fall out of sync also. If there is a basic health profile that we have to do, then we should be measuring the blood pressure, the blood sugar levels, perhaps the fasting insulin and HbA1c, definitely the CRP, and we should be looking at the lipid profile. As I told you, that the only abnormality that I saw in the chemistry of that lean patient was low HDL.
Okay. Bé hai giờ rồi nè.
So if
Con vừa rồi anh thấy ngáo vui nè rồi đi. Bé sao giờ nè, bé hai 15 minute. Nhưng mà cái bên này trả cái. Itu kan mate.
sir, आपका mic. So if we look at what sleep does to insulin and to insulin resistance, for a normal human being, there is something that we call as dawn effect. So there is a blood sugar surge around 4 to 8 a.m. In a normal adult, the insulin helps the liver, muscle, and fat to take up this glucose. And hence the fasting insulin level reflects insulin sensitivity. Because if your body is sensitive, then a little bit of insulin can do the work. And if it isn't, then the fasting insulin rises. So the first parameter that you can detect metabolic syndrome with might be either a depressed HDL or a raised fasting insulin. Now, what does staying up late or being sleep deprived do? Sleep deprivation increases cortisol, which again causes disordered glucose metabolism and causes increased insulin resistance, hence increases the amount of insulin needed. In fact, a single week of sleep deprivation or a single night of no sleep is equivalent to 6 months of high fat, high carb diet. And that is a very big burden. 62% of people in pre-diabetic range have poor sleep compared to 42% people who have normal blood sugars. But just like poor sleep increases blood sugar, high sugar also decreases the quantity and quality of sleep. So it's a vicious cycle. What is pre-diabetes and what is diabetes? So though there are clear-cut blood sugar cutoffs that we see, the raised insulin will be traceable in the blood for nearly 10 years before clinical diabetes is detected. And for 10 years, it is causing all the metabolic, vascular, and other changes in the body. It is too late when we finally come to the diabetic stage. Pre-diabetes is defined by normal glucose level, but high fasting insulin or high circulating insulin. At this stage, the ocular vascular disease, the retinal vessel changes can already be seen with a blood sugar at or around 120. The insulin resistance keeps increasing. The insulin levels keep increasing till the sugar can no longer be controlled. And that is when you land up with clinical diabetes. The strategies to reverse insulin resistance can be many-pronged. You can look at diet and nutritional strategies. You can look at exercise and activity strategies. You can look at stress management and cortisol strategies. I would add, in fact, in this, even adrenal fatigue. You can look at sleep regulation and growth hormone leptin-ghrelin axis, and you can look at pharmacologic strategies. But reversing insulin early prevents vascular disease, reverses metabolic syndrome, and improves health. And most of them are quite doable. I mean, stress is something that you can't control, but your response to stress perhaps can be controlled. So when the cells in the skeletal muscle, liver, and fat do not respond to insulin like they should, we are having insulin resistance firmly in place. Functions of insulin are to increase the uptake of glucose by liver, fat, and muscle. Also, it encourages the liver to form glycogen and put it in storage in liver, muscle, and fat. It turns off the breakdown of glycogen. It also allows the cells to take up amino acids and move towards synthesis of proteins. It also helps in DNA synthesis. So insulin is an anabolic hormone which turns off protein breakdown. It turns off gluconeogenesis because it is sensing available plasma glucose. When the plasma glucose rises, say after a meal, or when it stays risen, say as in a pre-diabetic or a diabetic, it stimulates the beta cells of pancreas and it actually suppresses the alpha cells of pancreas. The alpha cells would otherwise secrete glucagon. Beta cells secrete insulin. When the insulin rises, it works on the liver, muscle, and fat cells, and some other cells which have insulin receptors to increase glucose transport into the cell. The action of insulin in all of its sites is to increase glycolysis, to increase glycogenesis, and to increase lipogenesis. Now, when the insulin is taken up from the extracellular space, the plasma glucose falls, and this indicates to the beta cells that they need to stop producing more insulin. That's the normal insulin cycle. But when there is persistently high blood sugar, the cycle goes out of sync, the pancreas get exhausted. In fact, in type 2 diabetics, the glucagon is also increased, and there is increased glucogenesis, decreased glycolysis, and increased circulating glucose. Paradoxically, this circulating glucose is increased, but intracellular glucose, because insulin is unable to do its work, there is intracellular starvation. Incretins are glucagon-like peptides which are secreted in the small intestine, and they start working even before the blood glucose rises. And we see that incretins are also reduced in diabetes. They drive satiety, they reduce gastric emptying. So that could be one of the reasons why the diabetics feel hungrier. They stimulate insulin and hence keep the blood sugar under control. So the incretin axis also is deranged in the pre-diabetic and diabetic patients. What is the basic difference between type 1 and type 2 diabetics? In type 1, there is no insulin. So there is no response to raised circulating glucose. There is persistent hyperglycemia, but there is intracellular hypoglycemia, and the liver senses this to release more glucose into circulation. Similar response from skeletal muscle, but the skeletal muscle now has been shown to be an organ in itself which could be releasing myokines, which are cytokines that drive inflammation. Also, the insulin-driven uptake of glucose is lacking. So the hyperglycemia cannot even be mopped up. That is why you would say कि इनको sugar देनी ही नहीं है in patients को. In type 2 diabetics, there is insulin resistance. There might be some insulin, but there is beta cell dysfunction, there is excess glucagon and increased circulating glucose. There are decreased incretins, hence the insulin cannot even be triggered to the rising blood sugar levels after a meal. Initially, the increased insulin production is able to keep up with the demand, so there is hyperinsulinemia. Gradually, the hyperglycemia can no longer be matched with increased output, so there is clinical diabetes. So the model is that there could be insulin resistance in hyperglycemics with inappropriate elevation of glucagon and circulating glucose being higher than safe levels. In hypoglycemia, there is impaired insulin sensing and insufficient response to glucagon secretion. So there is, again, increased circulating glucose. In normal people, the response of glucagon and of insulin is matched so that the blood sugars are controlled. So we have the internal starvation paradigm. As I said, the circulating glucose is more, but intracellular glucose keeps sensing starvation. Or there is overflow paradigm, that everywhere the insulin receptors are overwhelmed. So measuring sugars, I think we all know these values, but I would say that adding fasting insulin to the mix would be a good strategy to pick up pre-diabetics and put into place some lifestyle measures that reverse that. So what is metabolic syndrome? It's not all that complicated. You could be suffering for nearly a decade before the blood sugars actually start to show clinical diabetes. A regular eye examination can often pick up diabetes before sugars show clinical diabetes. In fact, in our own hospital, we have a retina program for diabetes detection. The increased risk for cardiovascular disease, atherosclerosis, and microangiopathy begins in the pre-diabetics. So when we say that, even well-controlled diabetics can have microangiopathy, and this is related to the duration of the disease, it seems like it is those early days where it goes undetected or unmitigated is where the damage begins. Monitor yourself, educate your patients. It's a pandemic that we can deal with if we take measures now. We did this, I think, about a month ago, that the metabolic syndrome is characterized by high blood sugar in both the lean and the so skinny fat and the fat, the high blood pressure in the fat people, low HDL. As I was telling you, in that lean person, I saw low HDL, high triglycerides in both, and excess fat around the waist in the fat metabolic syndrome. The metabolic syndrome treats the two sexes a little differently. There is a sex-specific regulation of inflammation. So in males, the pro-inflammatory IL-6 and other cytokines with monocyte in monocyte activation, MCAS, is more. Whereas in females, the anti-inflammatory adiponectin is less. The net effect, however, in both is increased inflammation. So metabolic syndrome, or the X syndrome, is marked by high blood pressure, higher than 130 by 85 in both men and women, by an absolute measure of waist more than 40 in males and more than 35 in females. But I would say that we should look at the waist to height ratio and the waist to hip ratios for better evaluation. The waist to height ratio should be less than 0.5 and the waist to hip ratio should be less than 0.8. The triglycerides, HDL, and their values are important to measure. Fasting glucose and fasting insulin are both important to measure. So in metabolic syndrome, we would say that any three of the five would raise the flag. If there is insulin resistance, the fasting plasma glucose will be high. If there is vasoconstriction, then blood pressure will be high. If the liver glucose metabolism and lipid metabolism have already got deranged, then triglycerides will be high, HDL will be low. But this trigger comes from abdominal obesity and either a big waist or the wrong waist to hip, waist to height ratio. In overweight or obese individuals, the cardiometabolic risk is very high. It is further affected by inactivity, unhealthy nutrition, pre-existing hypertension, hypercoagulable states. But the abdominal lipid metabolism, where the LDL rises, where the ApoB rises, HDL falls and triglycerides rise, these significantly affect the cardiometabolic risk. as we have seen, the insulin resistance is detectable early by lipid derangement, by increased blood pressure, and by increased fasting glucose. All these factors not only affect the cardiometabolic state, but also cause a lot of other problems that we will just go into. So in the lean individuals, the M2 macrophages are driving the T regulator cells to keep Th2 response dominant and be anti-inflammatory. Whereas in obese individuals, the mast cells, the Th1 response, the M1 macrophages, and the ischemic oversized adipose cells, all of them cause rising TNF alpha, IL-6, IL-1 beta, and circulating chemokines to drive a pro-inflammatory state. The macrophages and the lymphocytes actually can work on the adipose tissue and keep a constantly triggered hyperinflammatory, chronic inflammatory state, which then becomes end stage CVD, type 2 diabetes, hypertension, and hyperlipidemia. When there is decreased lipolysis, the adiponectin rises, which is counter-inflammatory. IL-10, IL-4, and IL-13 make the body more sensitive to insulin and are driving the anti-inflammatory response of the body in a normal individual. In obese individuals, the hypertrophic adipocytes themselves are ischemic. There is increased lipolysis with increased free fatty acid available. There is decreased adiponectin, which triggers mast cells, neutrophils, and which deranges the monocyte macrophage response to be in the pro-inflammatory state, where the interferons Th1 response, TNF alpha, IL-6, interferon gamma, and IL-1 beta promote insulin resistance. So all cells of immune system are involved in these derangements. The excessive intake of energy, carbohydrate, fat, whatever, plus sedentary lifestyle causes both hypertrophy and hyperplasia. That means increased number of adipose cells and increased size of adipose cells. The net effect of all these is rising TNF alpha and IL-6, increased free fatty acids and triglycerides, decreased glucose uptake in the muscle, and increased free fatty acid influx into the muscle. Similarly, increased free fatty acid and triglyceride into the liver, which releases more CRP and fibrinogen. All of these are causing insulin resistance. So all the effects of increased need for or triggered insulin are deranging metabolism at multiple levels, not just of glucose, but of fats also. So as I said, the risk factors, though, could be abdominal adiposity, fasting glucose, insulin resistance, but all these are also effects. Hypertension is an effect of metabolic syndrome. Neurological disorders, including Alzheimer's, are seen more commonly in metabolically deranged PCOS. Some cancers, as we saw last time, cancer of the ovary, cervix, breast, some central nervous system cancers, cardiovascular disease, non-alcoholic steatosis of the liver or steatotic hepatitis. The stroke risk is markedly raised. It's not just the insulin which causes all these problems. So there can be decreased leptin sensitivity also. If insulin sensitivity is decreased, if insulin resistance is increased, the leptin also goes through similar cycles. When there is decreased leptin transport across the blood-brain barrier, there is derangement of hypothalamic regulation of energy homeostasis. So there is decreased restraint on pancreas for insulin secretion, and hyperinsulinemia is the result. There is decreased glucose metabolism in peripheral organs. So there is circulating blood glucose rising, and there is decreased energy expenditure. So there is rising blood glucose. Now, all of these can also be contributed to by carbohydrate dense, high glycemic index diets, processed foods. The hyperleptinemia is also going to cause similar derangements, because it drives the adiponectin values, and the adipogenesis and obesity itself cause leptin levels to rise, but trigger the leptin resistance. As I told you, the muscle itself is now taken to be an organ system, and the muscle releases several myokines and cytokines, primary among them being IL-6, IL-4, IL-7, IL-15, myostatin, which work on several tissues. They work on the bones, the gastrointestinal tract, the pancreas, the blood vessels, the macrophages, lymphocyte, kidneys, suprarenals, liver. They increase the abdominal visceral fat through the IL-15. Also, the adiposity is increased, inflammation is increased through IL-16. When the muscle is active, the fat metabolism veers towards increased lipolysis as well as browning of the fat. Now, brown fat is supposed to be healthy fat. So either by overeating or by decreased physical activity, the visceral fat increases, the leptin increases, and adiponectin decreases, which drives a neurally mediated pro-inflammatory stage. The ROS activation causes, again, a neural axis to be activated. The RAS activation causes hypertension and chronic inflammation. The visceral adiposity in itself is marked by increased fibrinogen, CRP, IL-6, and TNF-alpha. The free fatty acids, which result from increased intake or decreased disordered metabolism, affect glucose uptake in the muscles and actually drive the free fatty acid uptake by the muscle. All these derange the lipogenesis and the gluconeogenesis. Hence, the metabolic syndrome is marked by deranged glucose and deranged fat metabolism. Now, time-restricted eating or intermittent fasting can reverse a lot of effects of insulin resistance. It can reverse insulin resistance. It also promotes autophagy. Autophagy is when the cell is not able to pick up nutrients from the extracellular space, it starts to look inside the cytosol to pick up what it can to eat. So the cell starts eating itself. Now, when that happens, the immune system gets triggered to deal with the cell debris. And this constant priming keeps the immune system active. Also, autophagy results in decreased body fat, because fat is the first target for autophagy. So if you look at all the effects that time-restricted eating or intermittent fasting can do, and in fact, in most of our cultures, मतलब जैनों में, जैनिज्म में करते हैं, काफी सारे हमारा सूर्य अस्त के बाद खाना नहीं खाना. You know that I still see a lot of conservative Jain women who come and say, no, we'll not eat after 6 o'clock. So it improves your quality of life. It improves the sleep quality. It decreases the hunger. People who actually do intermittent fasting don't feel so hungry. And it decreases the oxidative stress, decreases the inflammation, decreases the bad lipids, and it improves the gut microbiome. It decreases the blood pressure, decreases the bad lipids and increases the good lipids. So all in all, time-restricted eating or intermittent fasting is a sustainable health strategy. That is the nutritional way in which to improve insulin sensitivity. If we were to look at the next one that we labeled the stress or cortisol, if you want to lower your cortisol levels, do follow similar sleeping cycle every night. We do say that 7 to 8 hours of sleep is necessary, but I feel like our lifestyle and our life needs are individual. And if you feel like you're fully rested with 5 to 6 hours of sleep, that could be your need. It's not set in stone that you have to sleep 10 hours every day. Practice mindfulness and meditation, which reduces cortisol, which promotes the vagal mindset, which decreases inflammation. Lower simple carb consumption in the morning when, as I told you, the cortisol levels are also high and the sugar levels are also high. There is the dawn surge. And laugh often. I think हमारी branch से आज कोई Mother's Day में laughter yoga भी कर रहा है. So laugh often. It opens up the blood vessels. It improves the circulation, decreases the cortisol. Exercise every day. The don'ts are: keep your sugar consumption to a minimum. Don't overwork yourself. Learn to take breaks. Avoid negative people who bring you down. If you feel like you don't like somebody, it is better to avoid than to be stressed. Be careful with exercising also. More is not always better. And we have seen that in the recent news of so many fitness models dying early. Avoid being overcritical or too serious all the time. It's good to have fun. Now, symptoms of adrenal fatigue are also similar. There is weight gain, puffy and flushed face, mood swings, increased anxiety, poor sleep, increased urination, irregular periods, excessive thirst, change in libido, muscle aches and pains, high risk for bone fractures and osteoporosis. All these things happen with adrenal fatigue also. And these are features of high cortisol also. If we go into a fatigued body, the immunity is reduced. There is lightheadedness, poor memory, overweight, hair loss, But do you see what is common to all of these? These are all present in long COVID. There has to be a way in which to reverse your adrenal fatigue. What can you do today to start taking action to a better health? If you can't do 15 to 20, 30 minutes of meditation every day, just practice deep breathing for at least 1 minute. The relaxation response itself will reduce the stress. Eat nutrient dense local anti-inflammatory foods जो सर कहा करते थे. You can practice time restricted eating or intermittent fasting. As we said, it improves immunity, improves autophagy, and improves metabolic health. You move more, exercise a little more. You can use the nitric oxide dump, which gives you the maximum benefit, bang for the buck. Up 4 minutes mein you can do 30 minutes worth of exercise. The 6-minute walk test itself is added. The HIIT, definitely, that is high intensity interval training. That if you can raise your heart rate intermittently, raise it, allow it to come down, raise it, allow it to come down. These exercises really remarkably increase the insulin sensitivity. Improve sleep hygiene. So we had said diet and nutrition, exercise and activity, stress or cortisol levels, sleep and ghrelin axis. Pharmacologic strategies we would not like to go into right now because that's a specialist topic. But knowledge is power. Just knowing that you can do something can set you on the path to doing it. And if we educate our families, friends, and patients to a better health, to a better metabolic health, we can create a population which can be the firewall to any emerging pandemic, including and not limited to the ones like we've seen in the last 2 years. You cannot take your health for granted. You cannot take anything for granted if this pandemic has taught us anything. So live deeply, love deeply, breathe deeply, and create a better world, one person at a time.
डॉक्टर निधि, आई वांटेड टू नो सर कौन से फूड बताते थे जो हमारी इम्यूनिटी बढ़ाते हैं?
वो कहते थे कि व्हाइट फूड्स, प्रोसेस्ड फूड्स मत खाओ. सो चीनी, चावल और दूध मना करते थे.
नमक भी कम ही खाना होता है.
और नमक भी कम ही खाना होता है. और वो he used to say that we should have predominantly raw diet and predominantly unprocessed carbohydrates. So of course you have to cook vegetables, but it's like sattvic bhojan.
Right. तो अगर जैसे हम मिल्क कम करें डेयरी प्रोडक्ट को मान के, तो इज सोया मिल्क अ बेटर ऑप्शन?
Soy milk, almond milk, all these milks are now on the rise for consumption also. Soy milk में I think हमारे phytoestrogens बहुत हैं, तो men don't prefer that and they can go for almond milk.
But it's good for women.
But I think जो आज Mother's Day है ना, we must take a little time to actually thank our mothers for the mitochondria that they have given us, if not for the life that we owe them. But so it's a human race needs to go back to the roots. We need to जो हम experience करते हैं वो तो हम देख ही रहे हैं ना. I mean we see what kind of commitment all parents, why just single out mothers, but all parents have to their children. This is the most selfless love that you will see. But even biologically, you owe your mental abilities. So it is said your mathematical and calculating ability is inherited from your mother. Your ability to deal with science is inherited from your mother. Mitochondria are inherited from your mother. So
Great.
I think take a moment and say thank you to your mothers and say thank you to yourself.
Of course.
Self-love also.
Yes.
मैं तो जहां भी देखती हूँ ना take a deep breath तो automatically take a deep breath हो जाता है. I think we should have that as a screensaver. Take a deep breath, which should come.
We said it before, but I think we actually need to do it
Yes.
because it suddenly calms you.
Yes.
आपने जब बोला, I did it for myself, and suddenly you feel calm.
And
So
that's
any
not
questions,
difficult.
anybody? It's a wonderful topic, Dr. Nidhi. I think जितनी बार बात करो, महीने में एक बार जरूर बात करो.
It's a wonderful
Obesity,
topic, but I
insulin.
think we need to create lifestyle changes for people.
Yes, yes. हम खुद ही नहीं अपने लिए कर पा रहे. उसमें तो क्या? मैं तो नहीं अभी तक कर पाई.
आप वो 1 minute deep breath ना अपने फोन पर लगा लो.
हाँ, वही करना पड़ेगा. बहुत फर्क पड़ जाता है.
आज शाम को आ रहे हैं आप?
डीए में?
पता नहीं.
सोचा नहीं था. सोचा नहीं था because East Delhi is tiring in itself.
Okay.
Of course, lots of आप आ रहे हैं?
आ रहे हैं, हाँ.
अच्छा, चलो, then I'll give it a try. If not for anything, then to meet you.
Just to meet.
Yeah. What time will you be reaching?
Well, they have said that they will start around 7 o'clock, even though the program says 5 o'clock. So we'll see
I know,
how
I read
we.
somewhere कि 5 बजे बोला है उन्होंने.
हाँ, वही कह रही हूँ कि उन्होंने जो ग्रुप में डाला है वो 5 बजे डाला है और फिर ये बोला है कि 7 बजे तक शुरू होगा. तो वो बड़ा.
See, it means 5 बजे से लेकर सिर्फ speeches और welcoming the chief guests and उनकी speeches. That's what happened in East Delhi also yesterday.
But it becomes tiring, नहीं?